work in the OBGYN area,
Okay.
so she likes it a lot.
Yeah. Yeah, definitely nurses, they either like it or they don't. Like it's a very polarizing. You like the fast pace and having two patients all the time, or you don't, you know?
Yeah, for sure. My mom was an ER nurse, but now she kind of works in like insurance. So
Yeah. So she likes fast pace.
yeah.
And she probably wants you to be a nurse too, I would guess.
Yeah, right now I'm leaning towards nursing. I was pre-med, but I keep changing, so I don't know. This is why the shadowing things are here. That's why
Yeah.
they're here, so.
Yep.
All right, we can start around 7:05.
Okay. No problem. Do you like Michigan State?
Yeah, I actually really like it. I wish it wasn't all online right now. It would have been definitely a better experience to go in person and like walk around campus, meet people, but we can't do that right now, unfortunately.
So you're virtual for the end of the semester or until, because the rates are going down too for you guys, so.
Yeah, so for now, the rest of the semester is virtual. I know that there are some in-person like lab classes and stuff, but I'm not 100% sure. For me personally, all my schedule is online, so I really don't leave unless I have to go to work. I work as a CNA, so whenever I have to work, that's the only time I leave the house.
Oh, okay.
Yeah.
Yeah. Is your family from Michigan then? Is that where you're?
Yep. Yeah. We only live an hour away from campus. I actually have an apartment near campus. So me, my sister, and two of our roommates live there. But we come back really often.
Mom's food is better, right?
Definitely. We're actually all like really interested in like cooking and stuff, and we like try different cuisines all the time. So we all take turns cooking dinner throughout the week, and it's really fun.
Yeah. I remember doing that in college, just like basically handing my mother like Tupperware, like driving home, fill it up, lady, and I'm taking it back.
Yeah, my mom always makes like a whole feast when I come home. She's like, okay, here's your food for the next 2 weeks.
That's like the best. It's the best.
Yeah.
Way better than your 99-cent spaghetti, you know, that you get.
Yeah, or mac and cheese, you know. Yeah.
I'm sure I'll do that to my kids eventually.
Yeah. All right. It seems like we have quite a few people joining. So I'm just gonna introduce you real quick.
Okay.
So hello everyone. Welcome back to My Medical Message. Thanks for joining today. So today we have Dr. Jennifer Roelands, and she's an OB-GYN doctor. And she's here and prepared a wonderful presentation for all of you guys today. So please post your questions in the chat and she'll get to those. So welcome to our page, Dr. Roelands.
Thank you very much for having me. I'm excited to be here. Do you want me to go ahead and open up the screen?
Yep, you can go ahead and share your screen. Yep.
Sounds good. Okay, so my name is Dr. Jennifer Roelands. I wanted to talk not only about OB-GYN, because I'm an OB-GYN, but also about integrative gynecology, because that's something that I am passionate about. It's something I've sort of moved towards. And so I'm just gonna, when I do talk a little bit about the different cases, I thought I would just bring a little bit on the difference between a traditional route on what a traditional OB-GYN would say, and then an integrative GYN would say, just so you guys can understand the differences between what it means to be an integrative gynecologist. There's integrative medicine, just for your own knowledge, is a fellowship. It's a 2-year fellowship that any specialty can do, not just gynecology. So you can actually also do it in internal medicine or family practice, actually anesthesia, surgery, whoever. It's just a fellowship for anyone with a medical degree. It can also, nurse practitioners can also participate as well. So it's for any medical professional. Maybe. There you go, about me. Okay, so I went to college at UC Santa Barbara. I got a BS in physiology, a Bachelor of Science in Physiology. I did not know I was going to be a doctor, so I went to Central America for a year with UC Berkeley and basically did ecology research. So I tromped around the rainforest and learned all about plants and parasites and got very, very bitten many, many times, but it was fun. And then I decided while I was there to go to medical school. I'm going to answer your questions sort of as I go through. I'll just see if I can answer them here and there. And then at the end, if I miss anything at all, just shout at me. I'm happy to answer anything. You guys can also email me. So feel free at the end to share my email and if people want to chat about something. So I went to UCSD for my 4 years of medical school. And then I did my intern year. That's your first year of residency at Cornell in Manhattan. And then went to Duke for the rest of my residency, which for OBGYN is 4 years. So 3 years were at Duke and 1 year was at Cornell in Manhattan. You don't have to do them separate. You can be either way. It's up to you. I have been in private practice for 13 years in Columbia, Missouri. I also was a proctor, so I taught people how to use the Vinci robot machine, the intuitive surgical machine. It's used for a lot of different specialties. It's been FDA approved since 2005. So I've used it since I was in first year residency, so 2004 is when they introduced it. And so in 2005, I was able to be trained and to teach other people. In my private practice, I actually created a robotics committee where people can, of different specialties, so urology and OBGYN and general surgery, could all talk together about how to use the machine effectively. So there's a lot of leadership opportunities, even in private practice, to be able to talk to people about how to use the machine, basically the robot. I have 4 kids. I like to bake. That's my avenue for stress. Stress relief is baking. Those are my little cakes that I've made for my kids. I wanted to bring this up too. I also have a business, a Well Woman MD, which is a health coaching business. And I also have a podcast that's linked to that. So I actually talk about different women's health topics and bring on different women's health experts. Like I had a dermatologist who's plant-based, who talks about not using medications for things like acne and aging. She's actually into more holistic options. So I actually bring that to the podcast. That's the name of the podcast. And then also do a health coaching business. So I'm also happy to answer about physicians who have kind of side gigs, who do things on the side, because you don't have to just have your life all about medicine. It can also be about things that you're passionate about besides just delivering good care to people. The integrative medicine, just so in case you're not aware of, it means that you take alternative and conventional and put them together. It's all evidence-based. It's a fellowship, so it's board certification. So it's not like standing on the corner with crystals or something and saying that everything will be cured kind of thing. It's really science-backed. Let me see if there we go. I think I saw one in there that was, about COVID. So someone had asked about, how did COVID affect my profession? I think every single person in medical field was affected by COVID to begin with. We all had to do, when all this started in March, we all shut down just like New York did. We followed kind of what happened in New York, and most of us shut down to a very basic level. So in OBGYN, I really only saw emergency GYN patients and OB patients, because people who are pregnant have to be seen regardless. You have to deliver their babies. They can't wait till the pandemic is over. And so anything that was an emergency GYN, so if someone came in with bleeding or they've had severe abdominal pain, then I would actually see them. But other than that, the yearlies, we put everything off in April and May because we really didn't know what was going to happen at the time. We saw what was happening in New York and felt obligated to just take care of what we had to and put everything else aside. So even in private practice, you have to do the right thing, which means you really have to, be safe. And so we continued to see the patients that had to be seen, like the obstetrical patients, because they had to be seen, and then the emergency patients. Okay. All right. Oops. Okay, so in general, OBGYN jobs, you can actually be an OBGYN in private practice. You can be an OBGYN in academics. You can choose to do GYN only. There's a new concept called hospitalist, where you essentially just do hospital work. You're the 24-hour shift person. And when you're there, you cover anything that walks in the door, like any GYN, any ER, anything, you just cover that. You can also choose to do locums. And locums essentially is they pay you to say you're in the middle of Wisconsin and they need somebody for 2 months. So then you go out there and you help them for 2 months and come back. So it's kind of a job where you fill in essentially when people need you at that time. So a typical OBGYN day in private practice, I kind of broke this down in between like an OBGYN in private practice and an OBGYN in academics, because that's the most popular 2 routes. So in a private practice setting, I often joke for students who ask me, like, there's no such thing as a typical day in a private practice. When you are your own owner, your own boss, basically, you constantly have to change and do things all the time. So I wake up in the morning, I check to see who's in the hospital. Are there any patients in labor? Anybody who needs to be rounded on? Anybody in the emergency room? And then I kind of see how my day goes from there. I usually have a full clinic schedule. That means about 40 to 50 people slotted for the day. They're about 15-minute slots. Usually I'm double booked. And then, OB patients usually are about 5 or 10 minutes, and then GYN patients can be 20 to 30 minutes. You also have to take calls. So in my practice, there's 11 of us. So there's about 4 times a month I have to do 24-hour calls. That varies depending on how many people are in your practice. If you have 5 people, then you're going to take much more call. If you have 20 people, you're going to take much less call. So it's divided between the number of people who are taking call. In an academic center, it's really broken down mostly into there's somebody in the operating room, there's somebody in the clinic, there's somebody on call. So it's very much segmented because you're an employee versus your own business where you have to essentially do everything. So in a clinic setting in academics, you'll often have a clinic person, and then you'll have a labor person who delivers anybody who happens to walk into the door or takes care of anything on the labor floor. They also manage the emergency room, and then you'll have someone who's in the operating room who's doing their, whatever cases they have booked. So it's a very different kind of model. You typically have residents and students as well. So, you have to take into account, you're going to have other people with you, as opposed to private practice. There's typically not residents and students, unless you're affiliated with a actually academic center, and some of those private practice jobs have affiliations. So they teach students on their grand rounds, or they might let the students come into the cases with them. But in my private practice, we're not affiliated with the university. That's about a mile away. In a typical clinic day, I usually see yearlies. So those are people who are coming for their well woman exam. So pap smears, pelvic exams, that kind of stuff. Return GYN visits. So people who might have irregular periods, or they want to talk about birth control. They might have pelvic pain. Vaginal discharge. There's a lot of sort of return GYN problem visits that you could include. I see people who are newly pregnant who have ultrasounds to diagnose their pregnancy and give them a due date. And then I see people who have return OB appointments. There's typically about 13 visits in a traditional pregnancy. So you figure you see them at least that many times. They can sometimes be seen more depending on if they're complicated, like have diabetes or high blood pressure or something like that. Just check the chat real quick, see if there's anything. How can you make a patient comfortable if they are not specifically young girls? So I do see women who, oftentimes if you're young and you're a teenager and you're with your pediatrician, once they start asking about birth control or asking questions related to that, oftentimes the pediatricians get a little uncomfortable, and so they boot them to us. So in those settings, I often will ask, do they want their parent to be present? Do they want their mom there? Some do, some don't. Some of them are more comfortable with their mom being there, and some of them just want to talk about things that they can't talk about in front of their mom. So I usually try to ask them first, and I ask the patient, I don't ask the mom, because the mom will always want to be there. I always ask the patient and say, do you want your mom here? And then if they do, then I grab them from the waiting room. I also don't do an exam unless it's going to change what I'm doing. So if there's a true problem that I need an exam for, then I will, but I really try not to examine really young, like teenagers, because it scares them. You're not likely to get very useful information. And then, you scare them off to see a doctor for the next 5 years because they're just scared of the visit. So unless it's something that I think is going to change what I'm going to talk to them about, then I typically don't do an exam in those settings. One other thing about that is I do also have a patient portal. So if they want to, I often tell the teenagers, like, if you want to email me something you don't want to talk to your mom about, just shoot me an email, we'll talk about it. And a lot of times I get questions, through there, like, my boyfriend said this, is this right? Like that kind of stuff. And so I think that's an easy way, because some people don't always want to ask the questions in front of you, but they're much more comfortable if they can just email you. So I do have that patient portal, which I think is helpful. On a typical call day, they're about 24-hour calls. I don't work post-call. I used to. That means I used to work the 24-hour shift, and then I would go to clinic all day until 5 p.m. And that was about a 30-something hour day. I don't do that anymore. I'm over 40, not going to happen anymore. So now I just do the 24-hour. And I think that's honestly better for patients anyway. After a while, you get a little cranky, so it's not good to be in the clinic for that long. I manage, when you're on a 24-hour call, anything that walks through the door that is girl related is yours. So anybody in labor, anybody who thinks they may be in labor, any emergency room calls that the emergency room doctor feels like it's in your arena, anybody on the floor, like if someone came in, they were admitted for gallstones, but then they have a heavy period and the doctor's concerned, they're going to call you. You also round on any patients in the hospital that might have already delivered or are sitting on the floor because they haven't delivered and we don't want them to deliver. And then you do rounds. And typical calls for all specialties are similar, like whatever comes in the door and it's in your specialty, you have to cover. So that's typical for, it doesn't matter if you're a neurologist or whoever, you're on call, you're the person that manages them. Typical OR day, this is me with my buddy, the robot. I call him Frank the Tank because he's huge. So typically OR day, I have about 2 major cases, 2 minor cases. Majors would be like hysterectomies. I don't use an assistant because now I'm 13 years in and let's say 17 years in with using the robot. So I don't really need an assistant anymore. I operate about 1 day a week. If I'm not operating that week, sometimes I just take the day off or sometimes I just work in clinic. It's really kind of whatever I feel like doing that week, essentially. And in general, in private practice, you often don't have another assistant because it's expensive. So if you have a doctor helping you in your practice all day long, they're not making money. So usually you try to do things on your own without having an assistant, or the operating room, you ask the operating room to let you have somebody. So I thought I would run through a couple of sort of scenarios. Let me just check on the chat to make sure there's nothing that, oh, I think I answered that question already. Okay, and I'll answer the integrative gynecology thing in just a minute. So clinic scenario. So this is a patient, this is a typical scenario. I would see a 25-year-old with irregular periods for the last 4 months. She has periods every 3 weeks to every 2 months. So that's very irregular. The definition of irregular periods is if they're less than 21 days apart or greater than 35 days apart. So this meets for sure irregular periods. She really has no past medical history. She's young, she's healthy, she's never had children. That's what the G0 means. So things that you're going to be thinking about, you're going to ask her like, well, how long has this been going on? Like, what other symptoms do you have? Do you have weight gain, hair loss, constipation? Are you trying to have a baby? Are you wanting to be on birth control? Have you had any blood work recently? What are your periods like in the past? Is this all new, or have you always had this problem since you started having your periods? And in the back of your mind, you're always thinking, what is my differential? What are the things that I think that this could be, essentially? So in the back of my mind, I would be thinking of diagnoses such as PCOS, that's polycystic ovarian syndrome, and ovulation, or she's just not ovulating because she's either overweight or underweight. She could have thyroid problems. She could have diabetes. She could be taking her birth control pills wrong. Sometimes people just take them wrong and they get all kinds of crazy periods. She could also have excess exercise or stress in general. That's basically working at the part of the brain that tells the brain what to do and how to get your ovaries functioning, essentially. So she answers the questions that I asked her, and she says, well, I've had irregular periods for 2 years. I also have hair growth on my chin and belly. I don't want to have a baby right now. I'd like to be on birth control. I'm also struggling with weight gain, and I've not been worked up at all. So this kind of leads you to think about things a little bit differently. And so the top diagnosis in my brain would be something called PCOS, polycystic ovarian syndrome. So in clinic, you would explain to the patient why you think this is PCOS, because she's met the 2 criteria for PCOS are someone who has irregular cycles and someone who has evidence of male hormone excess. So that either could be by physical symptoms. So here she says that she has excess hair growth on her chin and belly, or by lab work. And so you can offer her lab work. And I usually do lab work because I want to confirm the diagnosis and rule out those other things that I was mentioning. So this is the standard sort of blood work that you would order for someone. Oh, I started mentioning this too. So someone with polycystic ovarian syndrome, the definition is kind of deceiving, because we used to say that people had to see cysts on their ovaries to say that they have PCOS, but now that does not make, it's not part of the criteria. So you just have to have irregular cycles, and you just have to have evidence of male hormones elevated. You do not have to see polycystic ovaries on ultrasound. And this isn't an ultrasound picture. And the person with the pencil sort of pointing out to these little black, they looks like a string of pearls is the mnemonic essentially. So not mnemonic, but the textbook phrase. And so the issues with PCOS is that there are several complications. Someone who has PCOS is considered like a pre-diabetic, and they are considered someone who has like destined to get metabolic syndrome or destined to have problems in the future. So a lot of these people will eventually have diabetes. They may struggle with infertility. They have a higher chance of certain cancers if they don't have regular periods. They also have a higher chance of gestational diabetes, and then higher miscarriage rates. Oftentimes there's two types of PCOS. There's women who have sort of heavier, we call it type 1 and type 2, or just sort of heavy set PCOS and skinny PCOS. And so women who are on the heavier side oftentimes will have issues with sleep apnea. So when they fall asleep, they have problems with difficulty with getting air into their lungs, and so sometimes have desats while they're sleeping. So it's a big issue. It's something that you see in young women, and then they eventually sort of become diabetic or have other health concerns later on. So the conventional, this is answering the question I think someone asked me about integrative gynecology versus sort of typical gynecology. So the conventional approach to someone who has PCOS is you offer her birth control. She's got higher levels of male hormones. What you want to do is lower those hormones, and you want to basically control the cycle. You want to give them what they're supposed to be doing on their own. And so birth control pills give you a very set ideal environment. And so you offer them a birth control pill. You also talk to them about weight management if they are overweight. An integrative medicine approach, which is like I mentioned, the alternative plus conventional put together, that's what integrative medicine means, is that you're going to really talk to them about what are the other issues going on? Like maybe they smoke, maybe they drink too much, maybe they don't sleep at all, maybe they're stressed out. What are the other components, the other lifestyle approaches that might be affecting the fact that they can't lose weight, might be affecting the fact that they are not doing well for their PCOS and having infertility. So you're really trying to make a plan that's more from a whole systems-based approach. So you're looking at nutrition, you're looking at lifestyle, you're looking at mindset. So you're going to address all three of those pillars of health, because ultimately they may end up wanting to be, some women say, I don't want to be on a birth control pill, it makes me mean, or I don't like it. And so they ultimately want to do the more natural route. So that's kind of where this comes in for me, and as an OBGYN, that I like the integrative approach, because I sometimes have women who are like, I don't want to be on a pill, I don't want to be on it for the rest of my life. So what can I do instead? So we come up with an optimal diet for them. We talk about the type of exercise that's actually optimal for someone with PCOS, because there is a difference in exercise, especially with PCOS. And then we talk about some of those cycle syncing practices, or what kind of foods actually will help get their cycle regular. So that's kind of a little difference. I hope that answered that question that someone asked me about integrative versus, conventional. So this is a typical OB scenario. So this is a 28-year-old patient who is newly pregnant. She came in with nausea and vomiting. She's got past medical history of Hashimoto's thyroiditis, which means she has an autoimmune disorder where her thyroid is not functioning. And she has no surgical history, and this is her first pregnancy. Her only medication is Synthroid. For some reason, I'm not getting any more chats. I'm wondering if you guys are still, everybody's still there. Will you just send me a little message and see? It's fine. Okay, great. Awesome. I'm like, did people fall asleep or what happened? Okay. So this lady here, maybe I went to, nope, yeah. So essentially, when you have, how much school is necessary to OB/GYN? So you have to do 4 years of undergrad, 4 years of medical school, and 4 years of residency. So 12 years on top of your standard, graduate from high school thing. And the majors don't necessarily have to be anything. I mean, in my class, I had a religious studies major, I had an English major, I had, it helps to be in science only because then you don't have to redo those classes. Like, so most people enter with a science degree because they're trying not to have to redo those classes. So if you're a religious studies major, you're gonna have to take all the science classes. And so they don't really want to have to redo and do extra courses. But I have, like I said, there was in my medical school class, there was a lady who was a religious studies major, someone who was an engineer. I mean, you can have all kinds of different majors. It just makes it sense to be usually in science. And then the future of OB/GYN in terms of technology and advancement, pretty much everything is, I mean, electronic medical record is a part of everybody's life now. There's no way to get around it. In 2010, the Obamacare law said if you did not get electronic records, then you would get less reimbursement per Medicaid or Medicare patient. So everybody went to electronic records because no one wanted to lose reimbursement. So I think it's just here to stay. I mean, the electronic medical record, the Vinci, which I use for technology, the robot for surgery, I think that's sort of the wave of the future. I like it. I like it. I think it's a nicer way. I like to be able to wake up and look on my phone and say, okay, who's in the hospital? I can read through their chart. I can do things. I could, in residency, I could actually order things through my phone, but in this particular program, Epic, we can't do that. But there's a lot of different programs. So it just depends on where you're at and what resources. If you're in a rural hospital, it's going to be paper chart because those hospitals don't want to pay the extra money to have a $500,000 electronic record. So the wave of the future is for sure, just like everything else, making technology make your life easier and less stressful. Okay, so hyperemesis is just when someone has severe nausea and vomiting. It usually resolves by 12 weeks. It's certainly more common if you have twins or triplets. And then you make a decision, do you keep them in the hospital or not? Do you send them home? And in this particular scenario, I would suggest that she would go home because she's able to tolerate some things. So again, a conventional versus integrated medicine approach. You can offer her Zofran. That's a medicine used for nausea. You can talk to her about eating small meals and avoiding foods that cause her problems. And then you can tell her to take over-the-counter Unisom or B6, both of which are shown to help with nausea. An integrative medicine approach, you're not only going to do that, but you're also, like I said, going to look at those lifestyle factors too. Is sometimes people who have terrible heartburn have terrible nausea. They smoke, they don't eat, and then they have nausea. So there's a lot of other things that contribute to someone who gets sick. So if you don't look at that sort of bigger picture, sometimes people can't afford food. And they have, 3 kids and they don't have the ability to pay for good food. And so they're eating stuff that makes them sick because that's all they have. So there's kind of a different approach to how you see somebody and how you treat somebody. And so that's what I like about integrated medicine. And so you're going to talk to them also about some natural supplements like selenium, zinc, and iodine replacements that help for people with thyroid problems specifically. You're going to offer them peppermint, lavender, or ginger essential oils, which actually have evidence to support they help with nausea. Acupuncture is also proven to help with hyperemesis. And so you're going to kind of like take a little different approach to helping that person with their nausea and vomiting. Here's another GYN scenario. I brought this up because this is about surgery. So the one thing that a lot of people who go into OB/GYN love is they like the fact that you have clinic, you deliver babies, and then you can operate. So you essentially can do a ton of things. You're the jack of all trades, or I should say jack, you're the Jane of all trades for me. And so you're always being able to do multiple things. So people will often choose OB over, say, internal medicine because you have the surgical part, and they'll choose OB over, say, surgery because then you also have the clinic aspect. So you kind of have a blend of a lot of different things. You definitely don't get bored, for sure. If you're bored, then you and I need to talk because you're not working hard enough. Let me see if there's anything else. So what do you do? Future technology? I already said that one. Okay. Since the uterus is a hollow muscular organ, how does it stretch in order for the fetus to develop? So it's hollow, but it has these interconnecting fibers. And so it's made up of all these fibers that are going in different directions. So it stretches like a balloon. So it continues to stretch and accommodate the baby. Not always, right? Sometimes people have twins and they deliver a little early because their body is essentially maxed out. The uterus says, this is it, I'm done, or these babies are coming. So it doesn't always get to 40 weeks, but in general, the uterus should be able to be to a 40-week size, essentially a 40 centimeter size. Okay, let's talk about this hysterectomy question goes well with what I was going to talk about. So heavy periods. So this lady is 45. She's had 3 babies. She has heavy periods. She's been having them for a couple years. She passes lots of clots every time she has a period. So she's a pretty healthy lady, except for she's anemic. So that's what that hematocrit of 30 is. It should be somewhere around 45 to 50. So she's enough anemic that she's probably feeling a little dizzy and lightheaded here and there. So you do an ultrasound because you're wondering, why is this lady having such bad periods? And you see this myoma, which is a fibroid. Fibroids are very hard. They are like having a baseball or a softball in your uterus. Like, they're extremely hard. Because they're made of this really dense tissue, they cause a lot of pain. They also push on the lining of the uterus, and then people get a lot of heavy periods because of it. So you talk to her about, well, are you done having kids? What is your ultimate plan? Because you're in your mind thinking this woman needs a hysterectomy or should have the option. So the options with someone who has heavy periods and fibroids is you could offer them a birth control pill and see if that helps. You can actually try to see if it'll control their cycles or not, barring that she can have a birth control pill. If she's had like a blood clot or unhealthy, she probably can't have a birth control pill, or smokes. You can also offer her some outpatient options, such as a uterine artery embolization, which I'll mention in just a second, and a surgical management with a hysterectomy. So uterine artery embolizations, these are really cool. These are done by interventional radiology. So over time, radiology, which most people know what that is, reading films and CAT scans and things, they have developed this interventional radiology field, and it has grown so much. There's so much they can do where they are basically keeping you from going to the operating room. The goal is, like, they're doing all these interventions so that people can have non-invasive or less invasive options. So a uterine artery embolization, the arteries that feed, or the artery that feeds the uterus, it has a lot of branches, the uterine artery, they actually go in and they put this little chemical that blocks off the uterine vessel. So it essentially stops feeding this fibroid, because the fibroid loves hormones, and so it grows and grows and grows, and it also likes the blood supply from the uterus, so it'll take it away and just keep growing. Well, if you cut it off, it's not going to anymore, and someone will actually have this fibroid shrink and get smaller, and oftentimes their pain and definitely their bleeding gets better. The side effect of doing something like this, they actually enter at the groin. So if you've ever heard of someone who had, like, say, a heart attack, and they went back to the interventional radiology to look at their heart, they had a fluoroscopy and had dye in there to see which vessels were abnormal. They actually do the same location in the groin and go through there. The downside is that some people get pain and fever, and sometimes it doesn't work. Sometimes you block this off and this fibroid shrinks, but just not enough. And so they still have heavy periods and they're still miserable. And so but it is a less invasive, because you just, same day procedure, you go in that day, you go home, and hopefully that will go away. The other option is a hysterectomy. And this was the question someone had asked about hysterectomy. There are several types of hysterectomy. The one that's the least invasive is a vaginal hysterectomy. So everything is performed in the vagina. There's no incisions on the belly, so it's less invasive because there's no incisions. No one has to really, there's not much to heal except for the stitch in the back of the vagina. It's often, the vaginal hysterectomy is really less common nowadays, because if you think about the way our population has changed over the last 15 years, people are much heavier, they have a lot of medical issues. It's just hard to do a hysterectomy on a 300-pound person. It's just difficult. So things have changed over the time, and now we do more laparoscopic hysterectomies and Da Vinci, which Da Vinci is the robot, and it really is a shoot off of laparoscopic. So it's the same incisions as someone who has laparoscopy. It's just that you use a robot to hold the instruments as opposed to another surgeon. Now Da Vinci also has single site, which is one incision through the belly button to do the entire hysterectomy, which I think is just as less invasive, just like a vaginal hysterectomy. And I'm actually also trained in single site as well. Hysterectomy, depends on which one you have. If you have the traditional open approach, you're going to take a lot of time off of work. Usually it's 4 to 6 weeks. This is usually about 2 weeks, and then usually about 2 weeks. So it's less invasive. People definitely have less pain. Really, the type of hysterectomy is is really determined by the surgeon, because it depends on where you come out in residency. I finished residency, let's say I'm 13 years, so 13 years ago. So we did a lot of laparoscopic. And so that I'm trained to do that. But if you were out of residency 20 years ago, you really didn't do as much laparoscopic. You probably did a lot more opens. So really it's surgeon specific on what people offer, because you need to be good at what you're doing. So if I don't do a lot of vaginal hysterectomies, I will refer them to somebody else who does vaginal hysterectomies if I think that person is a candidate, because I don't think that I should be doing things that I'm not doing multiple cases on. You got to keep your skills up, and you can't keep your skills up if you do 1 or 2 a year. It's just, I think that's my personal preference. I think if it was my mother, I would want someone who's done, 4 a month rather than someone who does 1 a year. So let me see if there's anything else. Oh, work-life balance. So OB is definitely a harder job when it comes to work-life balance, because when you're on call, you're usually up in the middle of the night. Babies are born in the middle of the night. So it's definitely one of those jobs that's a little bit more demanding than, say, internal medicine outpatient clinic, where you're basically there from 9 to 5 every single day. Nothing changes. You're going to go home and go to sleep. You're rarely going to be woken up. So a lot of now internal medicine doctors have hospitalists who manage their patients in-house. So they have hospitalists who admit them to the hospital and take care of them. And then they in the morning wake up and round. So it's a much more less stressful, I think, job, because, babies, like I said, are born in the middle of the night. So there's nothing you can do about that. If you're going to be an OB, you got to be willing to, jump at the hat and do it. So I typically, for work-life balance, for me, I like a good glass of red wine. I like hot yoga. I do these things that I balance those times for myself. So I make sure that I have set time. I have 4 kids. So I try to balance the time with my kids, and then, say to my husband, okay, at 9 a.m. on Friday for an hour, it's my time. I need to do something for myself. So I read, and I like to do hot yoga, like I said. So you really have to come up with your own plan that lets you be a good if you have something to de-stress yourself, you'll be a much better mom, you'll be a much better doctor, because you've taken time to yourself. That's the hardest lesson to learn when you have children, is trying to learn to spend that time to yourself. You always want to spend every waking moment with them, but you have to learn to make sure that you have self-care. That's hugely important, especially in this job where you could be sleeping, dead asleep, and they call you and say, we need you now, Dr. Roelands, now, the baby's coming, and you have to pop up and go be ready to deliver a baby. So it's one of those things that you have to learn to manage stress very well. So I think all jobs probably in medicine, you probably need to have a good day. I threw this in there because this is the Da Vinci machine. This is actually the where you put your face in. This is my daughter. Our hospital has this super cool thing where your kids get to go in and play with the instruments. So this is my daughter actually sitting at the console. It looks like a video game. And then this is the machine where you operate. And then this is a laparoscopic procedure. My son is actually getting little jelly beans out of someone's abdomen. It's like a little fake patient. So, and for all the women in the house, my daughter rocked it. She got 98% on the test over the boys. So just throwing that out there. I was just going to mention, there's a ton of videos on YouTube. I know we're on there now, but there's a ton of videos where, and this is a really cool one. All you have to do is put robot peeling grape or Da Vinci peeling grape. And basically you can see the precision of the instrument. This for some reason, PowerPoint doesn't have the video on there, but I would have played it. Essentially, you can see them literally peeling the skin off of a grape. The precision is incredible. It's less than a centimeter, the end of this instrument, and it's an incredible machine. So if you go to YouTube and you put in Da Vinci hysterectomy, you can watch over 1,000 videos of different hysterectomies. You can see literally the precision of it peeling the grape. And this is sort of just a picture of the difference between a laparoscopic case. You're going to be able to see you see well, but it's not the same as seeing the Da Vinci. And I wish I could show the video. I'm sorry, for some reason it's not letting me. So anyway, check it out. You guys all know YouTube because you're on it now. So just check it out and Google Da Vinci hysterectomy, and you'll get to see a lot of cases. Maybe. The last one I was just going to mention, I don't know if I'm just running through these scenarios because I think you guys had said for me to run through different scenarios that we see. This is sort of a labor and delivery patient to kind of end the rest of the ones that I typically see. So an OB scenario, I saw You can see a lady who's 32, it's her second baby, and she shows up to labor and delivery with a headache and just feeling terrible. She doesn't have any contractions. She's really not in labor, but her blood pressure is high. It's 150/90. And you check her cervix, and her cervical exam is this. She's 2 centimeters dilated, 75% effaced or thinned out. And the baby's head is at -2 station. +5 is it basically coming out. 0 is where it's sitting at the spine. And then so -2, it's up. So she's got a little ways to go. And in this patient, you are going to evaluate her for her high blood pressure. And you're going to monitor the baby. You're going to get some blood work. And what you're really looking for is preeclampsia. Preeclampsia is elevated blood pressure in pregnancy. If someone truly has preeclampsia, the decision is to deliver them if they're term, if they're over 37 weeks. And so in this scenario for this lady, I said she was already 37 weeks. So we're going to move towards delivery because our labs and our blood pressures reflect preeclampsia. Yeah, so here's the definition of mild preeclampsia is when you have blood pressures that are over 140/90. It's for everybody. There's no, I know sometimes patients will say, well, my blood pressure is high for me. It doesn't matter that in our world, 140/90 is our cutoff no matter what. They have to be taken at 2 separate blood pressure times. So 2 separate occasions, at least 2 hours apart. And then lab work that confirms that they have protein in their urine. And then you make a diagnosis of mild preeclampsia in this scenario. Some risk factors for preeclampsia usually occurs in someone's first pregnancy. If you're older, if you're over the age of 35, you have a higher chance of having high blood pressure. If you're obese, I mean, just like hypertension issues in general, if you're overweight, you have a higher chance of having high blood pressure. It tends to occur more in African-American population than in other races. People who have prior high blood pressure, if say they have high blood pressure and then they're fine when they had high blood pressure one time when they were younger and then they lost some weight and then now they're pregnant and gaining weight again, then they have a higher chance of having high blood pressure. And certainly people with IVF and multiples, multiples have pretty much, if you have twins or triplets or more, you have a higher chance of everything: gestational diabetes, high blood pressure, preterm labor, everything. Just put it all in the same category. You're at high risk because if you think about it, you have 2 people, right? You have 2 pregnancies. You have 1 pregnancy, but 2 people. So there's a higher chance of all these things that can occur. So on this patient, we made a decision to deliver her because she's term. If she was not term, if she was under 37 weeks and we thought that keeping her pregnant was important, then I would give her steroids, which is to mature the lungs on the baby. Anybody under 34 weeks, if you're concerned that you might have to deliver them for any reason, then you would give them steroids to mature the baby's lungs. And you would also observe her and see maybe when she settles down and is sitting on labor and delivery, then her blood pressures will go down. If they ever get to a severe range, even if someone's preterm, so that means her blood pressures are 180s on the top number, over 110s on the bottom number, then she's going to have to get delivered because we're going to get to a point which makes mom sick. And at any point that you get mom that could be compromised, then we have to make a decision that it's better for both to get delivered. So you deliver her. And since she had a prior vaginal delivery, then you would induce her essentially. So why would you pick OB? So let's just talk a little bit about OB. I've mentioned this before, but in my mind, and obviously every obstetrician may think something differently, but it's pretty fast paced. Like there's a lot going on. You can have a lot of things that can change in the day. I could be dressed in nice clothes, go to my clinic, and then someone shows up on the labor floor and I have to then put some scrubs on and go be ready to deliver a baby and also be in clinic at the same time. You obviously have to like working with moms and with babies. If you don't like moms and babies, this is not your field because I guarantee you they will bring all their children into your clinic and show off their kids every visit that they come to you for. So if you don't like kids and you don't like moms with kids, you're not going to enjoy this job because all of my patients who I've seen for years will bring all their kids in so they can see how they've grown. I can see how they've grown over the years and they just, it's a very family-friendly environment. Why integrated medicine? Why someone might consider it? Integrated medicine you can't do until you either, like I said, nurse practitioner, or an MD degree. So you're going to finish whatever you're doing in the medical field and then you do integrated medicine. And really why I'm doing it is because I want to offer different options for people. I want to make sure that they know that there's other things they can do besides just take medication. It's really about prevention. not diagnosing and treating. It's also about the fact that food is medicine. So food can be used, it's just as important, nutrition. If someone has PCOS or diabetes, if you change their nutrition and they get to an optimal body weight, you will change their life. So I think it's important to think of food as medicine as well. And then I like the aspect that you really treat patients as a whole. You're looking at all of their circumstances and trying to help them help those particular things, because sometimes it's a matter of everything else going on. All right, questions. Do you guys have questions? I'm looking at, there's nothing in the chat, so let me see.
If you scroll up, there should be a few more questions.
Okay, what options do you consider before performing a hysterectomy? I didn't say that in general. So basically, when I give someone options for a hysterectomy, they have to be done having their children, right? They have to, if you take their uterus out, they're not having any more kids. So we try, depending on whether age they are, if they're wanting more children, I oftentimes try medical options first. So birth control pills or the uterine artery embolization, if they're a good candidate. So we'll talk about just, I try to offer them medical and surgical options both. And some people already know that what they want, they're like, forget it, I want a hysterectomy. And some people want to try less invasive options first. So it just depends on where they are. Like a 45-year-old woman will often say, never mind, just to take the uterus out, or someone who's maybe in their late 30s might say, let's try some less invasive options. So it's really patient specific. It's amazing how many people make their decision on maybe what their mom did or what their friends have told them is the best choice. So really, I think it's, you as a physician, you always want to offer them all the options. That's what consent is, right? Is giving them rest, benefits, and alternatives of all your options, and then letting them make the choice and helping them through that, counseling them through it. Let's see, which specialties do you typically work with, in your opinion, when you think is the best time for girls to get their first GYN checkup? So most young people will get their first visit usually when they go off to college or right when they're about to go to college, or if they're talking about birth control or wanting to be on birth control because their periods are heavy and their pediatrician isn't comfortable talking about it. Sometimes I see patients because their pediatrician is just like, this is not my thing. And so I often will see them say at 15 or 16 because they're uncomfortable having that conversation with their pediatrician. But for their first GYN, like actual physical exam, the rules are now age 21. So we don't do pap smears, we don't do physical exams until they're 21, because really you're not going to do the pap, so there's no reason for them to get addressed unless they have a particular problem you have to address. So annual exams start at age 21. I think I answered the schooling question. I think there was a question here about pediatrician working with other, our GYN OBGYN the same. So GYN is just, OBGYN is both, right? Obstetrics and gynecology, and GYN is just GYN. So that's what I mean by when I said a job of a generalist, which is an OBGYN. So you do both OB and GYN, or just a GYN only job. The difference between an OBGYN and midwives. So different states have different rules. In Missouri, where I live, we have something called lay midwives. So lay midwives do not have to have any formal training. So they can literally put a sign up and say, I can deliver your baby. There are no formal training. So midwives, though, in general, have a 2-year training to become a midwife. That their midwife certification is 2 years. So it's a little different than what we do, because obviously I go through 4 years of undergrad, 4 years medical school, 4 years of residency. So I have 12 years of training. So from a training standpoint, it's not comparable. We do a lot of labor and deliveries now have a midwife and an OB working together. So a lot of practices have really adopted having a midwife for people who are very low risk, who can be managed by midwives in labor, and then we're there as a backup. So if something goes wrong, I can get that baby out in seconds. And so then we can work together in a partnership. So it's really transformed in a lot of practices to be, I don't have a midwife in my practice, but I'm in the middle of the Midwest. So we're a little less open to these ideas. So, but in California and New York and all those West and East Coast, it's all over the place. Very, very, very common to have a partnership together. Do OBs treat ovarian cancer? So GYN oncologists are the ones that treat cancer for females. So if you are an OBGYN and you want to become a GYN oncologist, then you not only do the 12 years I said, but you also do an additional 3 years. So there's 3-year fellowships in OBGYN. So an oncologist, a urogynecologist, so someone who does prolapse surgeries, and then fertility doctor, and also maternal fetal medicine, who's a high risk doctor. So those are 3-year fellowships. So you do what I did, and then you go on and do 3 more years after that. So I do not like to treat ovarian cancer. I really try to avoid doing that. I don't want to get into the scenario because ultimately they probably need lymph node dissection. They need a much more extensive surgery, and that's not something I do. So I hope not to get into things like that. I try to avoid problems. OBGYNs, pediatricians, we work close in hand. I know every pediatrician, they know me. You have to, when you are in scenarios where babies can not make it, where you can have to tell a patient, oh, your baby has missing part of their arm, or they may have a broken clavicle. I mean, you have to be able to work closely with pediatricians and say, because you both have to be able to talk to the parents in a loving and supportive way. And so if you're not comfortable with your pediatricians, it makes that conversation very uncomfortable. And you really want them to back you up. A lot of times things happen in labor and there's nothing you can do to prevent them. It just happens. Labor, unfortunately, there's complications that happen. And so you want to know the pediatrician is really saying, you know, Dr. Roelands did her best. We did everything we could. We tried to, you know, it was just a very difficult delivery. And so you really want to have a pediatrician who is on your side, who can back you up, and because they know that things happen and just in their world, things happen. So it's really important to have a very good relationship. And I mean, yeah, I just don't see that ever becomes a scenario. Really, we work really well together. In there. Let's see. Is because your field is directed to females, do all specialize in eating disorder mental health treatments as well? No. Most OBGYNs are females, about 80%, but that's because a lot of females choose female providers. But as far as mental health treatments and eating disorders, there are specialists that in the psychiatry world who I will refer people for eating disorders and mental health treatments, because a lot of times there's not just one particular thing. When you have an eating disorder, there's usually other things going on. Sometimes they have bad anxiety or depression or PTSD or other things that need medication, and that's really better managed by a psychiatrist. So that's really a psychiatry field. Let's see. What is the most unique complication that you've experienced when delivering a baby? Oh, Lord, that's a hard question. Unique complication. I delivered a baby that had a broken clavicle. So it came out, oh no, it actually had a broken arm. And it was, I mean, those kind of scenarios, you can have all kinds of things. I've done, like it had a broken arm, it did fine, but we had to essentially wrap the baby up. And so it was completely taped up for the first month of its life. So that's kind of, you know, nerve-wracking when you're the delivering doctor. You don't really want to have to see the poor baby taped up, but you have to do what you have to do. The baby just came out with its arm kind of sideways and then it broke on its way out. I've had to deliver, I got called one time to the ER. I was on call and they said, any obstetrician to the emergency room parking lot stat. And so I delivered a baby in someone's car who was in the parking lot. So that was a little bit entertaining. I've done stat C-sections where the baby had to come out. I've delivered a patient who had an amniotic fluid embolism, which is probably the worst complication we have to deal with in obstetrics. Essentially, the amniotic fluid goes to the heart and the lungs of the mom, and they have an 80% mortality rate. So it's very, very rare, very, very serious. The baby also has about an 80-90% chance of dying. I had a patient like that, and that was very, very complicated and scary. Baby did survive, mom did not. So it's not, like I said, it's fast paced, but it's definitely for someone who is, you know, can hustle, can do things, can go, can move at that sort of emergency room pace and is ready to go. Because it's definitely, you know, you talking to parents who may have lost a child or having complication, it's a hard job, but it has fantastic rewards to be able to talk to be there when someone has a baby. They remember you. It's amazing how many patients will see me like in the grocery store and they're like, oh my gosh, Dr. Roelands, you delivered my baby. Look at this baby. So you're involved in the coolest moments of someone's life, but you definitely have to be willing to deal with the complications as well. So it's a unique job for sure. How do you deal with patient death? So in that scenario, I actually got counseling as well because it's hard. It's hard to be involved in patient care and to have patients who don't make it. I'm sure this is, if you're going to go into hematology, oncology, or surgery, I mean, you will pretty much every field in medicine, you'll have someone who passes because that is what happens. And so you really have to find ways to, in the people who you work with, you want to have sessions where you debrief and talk about the scenario and try to work through maybe things that could have gone differently, or things that some people just need to talk about it and know that you did the best you could do. And so in those scenarios, oftentimes we talk to people about just, let's talk it through. And then I sought counseling for that particular scenario because for me, it was just hard to be involved in someone who had a baby and also passed. It was a lot. So I had to seek counseling as well. And I think there's nothing wrong with physicians who need to also do that. How do you deal with patients that are not cooperative and do not share background information for you to diagnose the case better? Oh, oh, that's a good question. So how do you deal with them? You try to figure out what is the reason behind why they don't want to give their information, honestly. Sometimes it's because they don't know the questions to ask, or they don't know what to tell you. Sometimes they're shy. Sometimes they had a traumatic experience. So oftentimes patients who are not very forthcoming with information usually are with somebody because they're uncomfortable in the scenario to begin with. So a lot of times I'll just kind of open up the conversation to the friend or the mother or whoever's with them and kind of say, well, what do you think is going on? What do you think is been going on lately? And so sometimes that person is really helpful in these scenarios because they'll say, oh, this, my brother's had this problem, or my sister's had this problem for 10 years. She's had pelvic pain. In the past, someone saw her and diagnosed her with PCOS. So you can get a lot of information sometimes from the family, which is helpful. And sometimes it'll open up the conversation so the patient will then think, they'll say, oh, no, that's not what they said, or they told me to take this. So it kind of sometimes can bring up what they need to bring up. And sometimes I just say flat out to them, I'm a pretty open book person. I'm a pretty open book doctor. So I'll just say, what's going on? It seems like you're upset about something, or it seems like you don't want to tell me something. Is there something going on? Are you not safe maybe at your house? Or you're not safe in your relationship? Maybe there's something going on. So I really try to just be open and say, what is going on? Tell me what's going on. And so sometimes you can actually just get that information by just being upfront with people and saying, I want to help you. So just tell me what I could do to help you. What can I do to help you? I really haven't had too many scenarios where I couldn't some way get the information out of them. Because usually if you can't, you just say, well, I'm sorry, I can't help you today. If you need anything in the future, let me know. And then, sometimes that opens up communication in the future. So you just have to be yourself. In being in medicine, you just have to be yourself and be open with people and say, I want to help you. You just have to let me know how I can help you. Let's see. What do you think is one of the most beautiful aspects of the childbirth process? I think the coolest moment of childbirth is when and same thing for what happened with me on my first son, is just, you see the kid, you see the baby, and the moment the mom sees the baby for the first time, it's just the coolest thing, because they're just like, oh my gosh, this thing came out of me. Like, look how beautiful it is. Look how amazing it is. And even if the baby looks like a hot mess, because it's been all cone head and all kinds of craziness, as a mother, you just think they're the most beautiful thing in the entire world. So I think that's the coolest part of childbirth, the coolest thing that I am involved in, because you see their face and you see their excitement and their joy. And it's just, that's amazing. It's really quite cool to be a part of. What are some procedures that you like to avoid unless they're absolutely necessary? Well, I really try not to do hysterectomies unless someone really doesn't want, unless someone really has no other options. Because it's permanent, so you try to talk them into other things that maybe they would consider. Other procedures that you avoid unlike necessary. Someone who wants like a tubal, someone who wants to tie their tubes, like say in their 20s, I often will say, I'm not sure you really, the highest rate of regret is someone who ties their tubes in their 20s. So I try to talk to them about other alternatives like IUDs or other birth control options. Maybe they just didn't know there was there's a ton of options nowadays. So I try to talk to them about, is this definitely, you absolutely do not want any children. And in those scenarios, I have occasionally tied tubes on someone who's in their 20s. And so, I try to offer them all the options. That's what a true informed consent means. It means that you've given them a risk, you've given them the benefits, and you've given the alternatives. So in any procedure that I go through, I try to say, these are the alternatives. Are these the alternatives that you want? So I try to do that because then you and the patient both feel comfortable with the decision of whatever you decide to do from a procedure standpoint. And this comes up sometimes in deliveries, right? Sometimes there's patients who you say, I think you need a C-section. They're like, nope, I don't want it. I don't want to have a C-section. Sorry. And you have to, it's sometimes a challenging situation to say, well, this is why I think you need a C-section. Your baby's heart rate keeps going down in the 50s. This is a problem. They're going to have long-term complications. Or most of the time when patients say that to me, and it doesn't happen very often, but when they do, it's because of fear. It's because they're scared. They don't know what to anticipate. They've read all about, they've watched the baby story on TLC. They've heard their friend's great, fabulous birth experience when they're, you know, in a tub at home and it was fantastic, and they don't understand why they can't have that same experience. So a lot of times those decisions, when someone seems to be someone not agreeing with you, it's really about fear. It's about not knowing what you're going to do and having these expectations of what they thought it would be, and it's not. So I really try to talk to people about what are you scared of, what's going on, and try to discuss with them, because a lot of times you can talk to them and they understand then what your concern was, why you just made the decision that you did. Okay, let's go get two more. Let's see. What does the setting look like when you are performing a surgery? Like, how many people are in the room? So in the operating room, there is a surgical surgical tech. So someone who actually passes the instruments to you. There is a nurse anesthetist, or a CRNA. There is an anesthesiologist. Those are the two people putting the patient to sleep. The scrub tech, or the scrub tech, is helping me hand me instruments. And then sometimes there's a assistant. So some operating rooms will have an assistant kind of hanging around, and so they will be able to help you if you need. And then there's always a circulating nurse. So someone who will go get things for you, who checks the patient in, who checks the safety of the instruments. Like, they're the person that actually just goes through and makes sure everything is running smoothly. So typically a nurse, and CRNA, anesthesia, nurse, and a scrub tech, and then me. So 5 people. Approximately how many babies have you delivered? Okay, so let's see. I just literally pulled this up because I'm leaving my private practice. I'm going to go do a hospitalist job because I'm building my well woman practice. I delivered I looked it up, it was like 175 to 200 babies a year. I've been in there 13 years. So I would say over 2,000 babies. And that was in private practice. Before I left residency, I delivered 450 babies. So probably 3,000 babies, somewhere around there. As an OB-GYN, what is your least favorite procedure to perform? I would say an endometrial biopsy. It's actually a little plastic catheter that you put through someone's cervix, and you go into the uterus and take a sample. We do this in clinic, and it's not under pain medication. So it's not very fun. So that's probably the thing I least like, because I know it's going to be painful. I'm not giving them anything for pain. So it's kind of one of those not pleasant experiences. Let's see. Do you talk with patients frequently about hormone balance? Do you have an example? So not as much in a traditional setting, because if you are in a clinic, you really only have 15 to 30 minutes, mostly 15 minutes to talk to patients. So I don't do that in the traditional setting as much. So that's why I'm doing the integrative medicine fellowship, and why I have the Well Woman MD business, because my goal is to help people who want to balance their hormones without medication. So I want to talk to them about their diet. Let's talk about a hormone balancing diet. Let's talk about stress and sleep. Let's talk about supplements you can take. Let's sort of work on that and have time to do it. You really don't have time in a 15-minute visit or 20-minute visit to go over that particular thing. So for example, since you said an example, so PCOS, polycystic ovarian syndrome, like I mentioned, someone who has PCOS has very irregular cycles. They're insulin resistant. So when their body secretes insulin, it doesn't break down sugars nearly as well. And so because of that, they usually gain weight, and they often don't ovulate, which leads to irregular cycles. So we talk about PCOS specific diets. A lot of people have a misconception that people with PCOS should be on a keto diet. That's like the worst diet they can be on, because keto is too strict. They have a insulin resistance, so their ability to break down carbohydrates is not the same as someone who doesn't have that problem. And so it doesn't make any sense for them to be on a strict carbohydrate 20 grams or less, like a keto diet, because essentially you're stressing their body out. And then they raise their cortisol levels, and then they conserve glucose or put the glucose into their fat, and then they gain weight. So you basically made their problem worse. So we talk about in my Well Woman MD business about PCOS patients. I have a course actually for PCOS patients, and we're talking about moderate carbohydrates. So 80 to 100 grams. We talk about normal hormone balancing fats, or the right fats to be consuming. We talk about the right exercise that's good for patients with PCOS, because you don't need to be doing high intensity exercise. That's not a good plan as well. So it's kind of a matter of like trying to work with whatever hormone imbalance they have, and then what is the right diet, exercise, lifestyle shifts like sleeping and stress reducers to fix their problem. So I like that approach. I think it's nice to be able to offer patients who want either one. There are definitely patients who walk into my office and who are like, I need a birth control pill. It's definitely what I need. And that's totally great too. I'm open to both options. So that's the reason why I have this as a side business, because there's just really not the time. Like I mentioned in my day, you don't have time to sit down and talk to people about what they eat. That's just, there's no time, not unless you want to see 5 people a day, and that would never work in a normal practice, because you can't make money. If you get paid $20 per visit and you see 5, you're going to be in trouble. It's hard to turn the lights on. So for that standpoint, this is why the integrated medicine approach is there, for sort of a different model, essentially. So hopefully that makes sense. I think I got most of them.
Yep. I think that's all for questions, actually. Okay. But thank you so much for being on our platform. This was a very informational, very enjoyable session. I know, because I'm very interested in OB-GYN. I really, really enjoyed this session. But yeah, thanks again for joining us. And to all of our viewers, there is a Google form that's posted, and we'll close at 8:30. So make sure you submit your response for your shadowing hour. Thank you.